Welcome back to the Deep Dive. This is the show that gives you that knowledge shortcut by slicing right through the densest research out there. Today, we're undertaking an exploration into a physical condition that is incredibly common, yet it's often shrouded in embarrassment or sort of dismissed with casual humor.
Yeah.
We're talking about male breast enlargement, the condition sometimes crudely referred to as man boobs.
And while those casual terms exist, for the hundreds of thousands of men who experience this, it can be a source of real psychological distress.
Yeah.
And crucially, it can be a signpost for underlying health issues.
Exactly.
So we're diving deep into the clinical reality of this. Our sources confirm its prevalence is just staggering. I mean, it affects men at every age, hitting 3 distinct peaks across the male lifespan.
So our mission today is very specific. We need to cut through all that confusion and define exactly what we're talking about because, as we discovered, not all male breast enlargement is the same.
Not at all.
We need to unlock the complex hormonal chemistry that causes the true glandular growth, detail the huge list of external triggers, especially the really common medications that cause it, and then finally, we'll review the full spectrum of management options available to you, everything from lifestyle changes to definitive surgery.
Right. And to start, you really need to understand the fundamental distinction in the source material. When we talk about breast enlargement in men, we are usually discussing one of 2 very different tissue types.
Okay, let's lock in those definitions first. What is the difference?
So the first one, and this is really the focus of our hormonal deep dive, is true gynecomastia.
Right.
This involves the benign enlargement and proliferation of glandular tissue, the stuff that's hormonally responsive.
Okay, so when a doctor does an exam, what does that actually feel like?
They'll feel a firm, sort of rubbery or tough disc of tissue that sits right beneath the nipple areolar complex. It feels very distinct.
And the second type, the one that's more associated with just general weight gain.
That is pseudogynecomastia. Sometimes people call it lipomastia.
Lipo meaning fat.
Exactly. The prefix lipo tells you everything. This is purely an excess accumulation of adipose fat tissue. It feels soft and diffuse, and it's typically strongly correlated with generalized obesity.
I see.
Now, a lot of men who seek treatment, they actually have a mixed presentation. They have both hormonally driven glandular growth and excess fat layered right on top.
So understanding which tissue is the main problem is critical for treatment.
It's everything.
That makes the diagnosis so much more targeted.
Yeah.
Okay, let's unpack this hormonal mechanism. If true gynecomastia is the growth of glandular tissue, what is the fundamental engine driving that in the male body?
Well, the male breast tissue is usually minimal, but it is sensitive to female sex hormones, specifically estrogen. So the growth mechanism is fundamentally an imbalance in the estrogen to androgen ratio.
The ratio.
It's all about the ratio. Think of it like a delicate scale. In men, the scale should be heavily weighted toward androgens, like testosterone. If that scale tips toward estrogen, the glandular tissue gets a growth signal. It just starts to proliferate.
So it's a constant battle for dominance. And the estrogen side is surprisingly powerful here. What are the key pathways, the specific ways the scale gets tipped that the sources highlight?
We can pretty much categorize the imbalances into 4 core mechanisms. The first one is straightforward, an absolute increase in estrogen levels. The body is simply producing too much, maybe from a tumor, maybe an external source.
And the second pathway is just the inverse of that, right? Not too much estrogen, but too little testosterone.
Exactly. The second mechanism is a relative increase in estrogen because of decreased androgen levels. If testosterone production goes down, even if estrogen stays the same, the ratio still favors estrogen. The scale tips.
That covers production. What about the ability of the hormones to actually, do their job?
That brings us right to mechanism number 3, androgen receptor defects. In this scenario, testosterone is there, it's in the bloodstream, but the tissues, including the breast, can't effectively respond to it. The receptors are either defective or they're blocked.
So the body senses a deficiency in the signal.
Right. It can't hear the testosterone.
And the fourth pathway, this is the one that connects back directly to body composition and our earlier distinction between fat and glandular tissue. This is what really links obesity to true gynecomastia.
Precisely. This is all about the increased activity of an enzyme called aromatase.
Aromatase.
Aromatase is found primarily in fat tissue, muscle, liver, and skin. Its only job is to convert androgens like testosterone into the potent estrogen, estradiol.
So if a man gains a significant amount of weight,
he literally creates more biological machinery, more aromatase, to convert his own testosterone into estrogen.
That is a critical insight. So excess body fat isn't just physically accumulating as pseudogynecomastia. It's chemically and actively fueling true gynecomastia. It's a double whammy.
It's a perfect double whammy. Yeah, it connects those two seemingly separate presentations beautifully.
Now let's look at the sheer prevalence. The sources show the number of men affected is just staggering because the condition hits 3 distinct, predictable peaks based on age. Let's start with the physiological causes.
These are known as the 3 peaks of physiological gynecomastia, meaning they're tied to natural hormonal phases in life.
Okay.
The first peak is neonatal gynecomastia seen in newborns. This is caused by the transfer of maternal estrogens across the placenta late in pregnancy. It's transient, resolves on its own within a few weeks. No intervention needed.
And the next peak, this is the one that causes the most public and private distress. Puberty.
That's pubertal gynecomastia, and this is an astonishingly common occurrence. It affects up to 70% of adolescent boys, usually between 10 and 14.
70%, that's a huge majority.
It is.
So it almost means experiencing this to some degree is the norm, not the exception, during those years?
It is, and this is why reassurance is really the main management strategy at first. During the complex process of puberty, the body has these massive surges of testosterone, but often the surge in estrogen or the activity of aromatase outpaces the testosterone for a little while.
So the good news.
The overwhelming good news is that this is transient. In over 90% of cases, the condition resolves spontaneously as the hormonal axis matures, usually within 6 months to 2 years.
That's huge. But for the boys who suffer from it, that can feel like an eternity.
Oh, absolutely. The psychological impact can be very real, but time is usually the definitive cure here.
And the final physiological peak applies to older men.
Right. That's aging, or senescent gynecomastia. This affects over half of men aged 50 to 80.
Over half.
Yeah. As men age, there's a natural progressive decline in the production of free active testosterone. That's coupled with that increased aromatase activity we talked about, which often goes along with age-related changes in body fat. Again, the ratio just tips toward estrogen.
Okay, so moving outside of those natural peaks, we get into the world of external triggers, the pathological and pharmacological causes. And this section is a crucial learning point, especially about medications. I think a lot of people don't realize their daily prescription could be the cause.
Medication-induced gynecomastia is one of the most common identifiable causes in adult men.
Yeah.
You have the obvious culprits first, right? The drugs intended to affect hormones like anti-androgens finasteride or dutasteride used for prostate issues or hair loss, or of course exogenous anabolic steroids.
But the list gets much wider and much more surprising. It hits these everyday drug categories. Let's maybe focus on the cardiovascular and GI drugs, because millions of people take those.
Absolutely. And that's where people are often completely caught off guard. Think about the drugs managing long-term, non-hormonal conditions. In the cardiovascular category, spironolactone is a major one.
Spironolactone.
It's a very common and effective diuretic for blood pressure and heart failure, but it structurally acts as a potent anti-androgen. It blocks testosterone receptors, essentially mimicking mechanism number 3 we discussed.
So it's not just lowering blood pressure, it's actively interfering with male hormones as a side effect.
Exactly. Other drugs in this category, like the heart medication digoxin and certain calcium channel blockers like amlodipine, they're also cited because they can interfere with hormone metabolism.
And then there are the anti-ulcer drugs. That seems totally unrelated.
Historically, yes. The sources note that certain anti-ulcer medications, specifically the H2 blockers like cimetidine and sometimes ranitidine, can cause this issue. Cimetidine in particular has a mild anti-androgen effect at high doses, again subtly shifting that E to A ratio.
That provides some really necessary depth. We also see effects from psychiatric, neurological, and even recreational substances.
We do. Certain psychiatric drugs like the antipsychotic risperidone and anxiety medications like diazepam, they can disrupt the pituitary axis, leading to hormonal changes. And sadly, recreational substances, long-term, heavy use of alcohol, marijuana, heroin, methadone, they all appear in the sources as potential triggers.
Why is that?
It's often due to their toxic effect on the liver or the endocrine system directly.
Beyond drugs, what about underlying health conditions? What are the big pathological causes?
Well, a vast array of diseases can cause this because the body's hormone metabolism is so interconnected. Anything that impairs testosterone production hypogonadism is a clear cause. We also have to consider tumors. testicular, adrenal, or pituitary tumors that might be inappropriately secreting estrogen or HCG.
And the link to systemic disease is really strong here, right? Often related to the body's inability to clear out hormones.
That's the key mechanism for diseases like liver disease, specifically advanced cirrhosis. The liver is the primary site for metabolizing and clearing excess estrogen from the blood. If the liver is sick, estrogen builds up. It's a state of estrogen excess.
Okay.
Similarly, hyperthyroidism is linked because an overactive thyroid increases a protein called sex hormone binding globulin, or SHBG, which binds up free active testosterone. It effectively reduces the androgen side of the ratio.
This complexity just underscores why a thorough diagnostic workup is non-negotiable. So if a man notices breast enlargement, what's the systematic approach a physician takes to figure out? Is it glandular? Is it fat? Or is it potentially something more serious?
Diagnosis is critical, not just for treatment, but because in about 1% of cases, breast enlargement can mask male breast cancer. The first step is, as always, a meticulous history.
Right.
The clinician needs to know the exact onset and duration of the growth, 6 months or 6 years. They need a detailed list of every single drug and supplement, and they check for signs of systemic disease like weight loss, pain, or decreased libido.
And then comes the physical exam. This is the moment of truth for telling the tissues apart. How does a clinician actually feel the difference between fat and gland?
The technique involves grasping the tissue between the thumb and forefinger. If it's pseudogynecomastia, the tissue will feel soft, diffuse, and the thickness is uniform across the chest.
Okay.
But if it's true gynecomastia, the doctor will feel that distinct, firm, often tender, rubbery disc of tissue precisely beneath the areola. The exam also goes beyond the chest. It means checking the testicles for masses, looking for physical signs of liver or thyroid disease.
So once the physical exam points toward true glandular gynecomastia, what labs are required to hunt down the cause?
If a pathological cause is suspected, we need blood tests to check the hormonal axis and systemic health. So liver function tests, thyroid-stimulating hormone, testosterone, estradiol, and often HCG to screen for those tumors. A very low T and high E confirms the imbalance.
And when is imaging absolutely necessary?
Imaging is essential if the mass feels suspicious, if it's unilateral, hard, fixed, or eccentric, meaning not centered under the nipple, or if the clinical picture is just unclear.
So you'd use a mammogram.
Mammography or ultrasound, yeah. It's the definitive way to confirm the presence of glandular tissue, measure it, and most importantly, differentiate it visually from a potential malignancy. Only once we've established it's benign can we move to treatment.
Right. Once you have that definitive diagnosis glandular tissue confirmed, say by ultrasound, that diagnosis dictates the approach. Let's pivot to what those management strategies actually look like.
Treatment is highly individualized. For pubertal cases, like we mentioned, the primary approach is watchful waiting and reassurance. The spontaneous resolution rate is just so high.
And for pseudogynecomastia?
The main treatment is lifestyle modification and targeted weight loss.
And we have to reiterate that crucial point from the sources about exercise here.
Oh, absolutely. You cannot spot reduce fat tissue, including breast fat, through targeted chest exercises like bench presses. It just doesn't work that way.
So doing 1,000 push-ups won't selectively burn that fat.
It won't. It'll improve the tone of the underlying pectoral muscle for sure, but it won't burn the overlying breast fat. Weight loss has to be systemic to have an impact.
And if it's due to a drug?
Discontinuation of the offending medication is often curative. Resolution can happen within weeks or months.
When do doctors decide to bring in medical therapy?
Medical therapy is key, but it has a very narrow window of effectiveness. It's really only useful in the early proliferative phase, typically within the first 6 to 12 months before the tissue becomes dense and fibrotic.
So once it's been there for a long time, it becomes more like scar tissue.
Exactly. It turns into scar tissue, and at that point, drugs simply don't work.
So what drugs are used to try and block that hormonal signal in that early phase?
The most widely studied and used drugs are SERMs, or selective estrogen receptor modulators like tamoxifen or raloxifene. Tamoxifen is usually preferred.
And how do they work?
They work by basically sitting on the estrogen receptor in the breast tissue, blocking the growth signal without affecting estrogen elsewhere in the body. Tamoxifen is particularly effective for cases that are painful or tender.
What about the drugs that block estrogen production entirely? The aromatase inhibitors.
Those drugs which block the conversion of testosterone into estrogen are theoretically perfect, right? Especially if you suspect high aromatase activity. However, the source material notes that their clinical success in treating generalized idiopathic gynecomastia has been less consistent than SERMs.
So they're for more specific cases.
Yeah, they're typically reserved for very specific scenarios where there's a confirmed extreme pathological excess of estrogen being produced, like in some tumor situations. For the common case, SERMs are the pharmacological gold standard.
Finally, we get to surgical intervention. This is the definitive fix, but it's reserved for long-standing or emotionally distressing cases.
That's right. Surgery is the definitive treatment for those long-standing cases that have become dense, fibrotic, and unresponsive to medical therapy, or for men experiencing severe psychological distress or body image issues.
And the procedure often involves two components, usually combined.
It does.
Walk us through those two surgical components and how they address that mixed presentation we talked about.
Okay, so the first component is liposuction. This removes the soft, adipose, or fatty component, the pseudogynecomastia aspect. Surgeons often use advanced techniques like VASER or laser-assisted lipo because the heat and energy from these tools can help break up the fat and, critically, stimulate the overlying skin to retract.
Which gives you a tighter, flatter appearance.
Exactly.
Liposuction can't get that firm, rubbery glandular disc, can it?
It cannot. That's why the second component is excision, the surgical removal of the glandular tissue. This is absolutely essential because that firm, fibrous disc just cannot be effectively removed by suction alone.
And the cosmetic goal here is?
The goal is to achieve a completely masculine chest contour with minimal visible scarring.
So where is that incision usually placed to minimize visibility?
The most common and best hidden approach is the perioral incision, placed right along the very edge of the areola. It camouflages the scar dramatically. Extended incisions are typically only used in cases with massive enlargement that has led to significant skin excess or sagging, a condition called skintosis, which necessitates skin removal.
This has been a truly comprehensive deep dive. To pull this all together, the central takeaway seems to be the need to distinguish between glandular tissue, which is hormonally driven and needs excision or medical therapy, and fatty tissue, which is weight-driven and best addressed by liposuction and weight loss.
That distinction is paramount. And if we connect this to the bigger picture, this common physical presentation, whether it's glandular or fat, it serves as a critical signpost for your overall systemic health and hormone balance. Given how many common medications, especially cardiovascular and psychiatric drugs, can cause this, alongside the strong link to issues like liver disease and obesity, an accurate evaluation is crucial. You want to make sure you aren't just treating a physical symptom, but maybe addressing a serious underlying health concern.
And for those for whom it's simply physiological or idiopathic, the treatment options are highly effective. Surgical intervention, in particular, offers a permanent and cosmetically satisfying solution. It can profoundly improve self-esteem and quality of life for men who suffered.
It really can. So our final thought for you to mull over is this. Consider reviewing your own or a loved one's daily medication list with this new insight. The hidden relationship between common side effects and daily drugs is so often overlooked. And understanding that link, that something as mundane as a blood pressure pill can shift your delicate hormonal balance, is the first step toward correcting the imbalance, sometimes without any surgery at all.